right. So number one, we have what CPT and ICD-10 codes are reported for a hemicolectomy that's performed on a patient with colon cancer. So how do you guys want to rule out? Do you want to rule out with CPT or do you want to rule out with ICD-10?
ICD.
Okay. So let's rule out with ICD-10. We've got two D49.0s. So let's go look at that. So D49.0 is for a neoplasm of unspecified behavior of your digestive system. Okay. Does that sound like what we've got? You want to keep looking?
No, that's not.
Okay. Yep. Correct. So then we have C18.9 and C19. Go to those. C18.9 is malignant neoplasm of the colon, unspecified, and then C19 is malignant neoplasm of the rectosigmoid junction. So which one do we want to choose?
C18.9 because it's the only one that specifies colon.
Yep. Yep, because it's the C19 is the rectosigmoid junction, which is not of just the colon. Correct. So that being said, we don't have to go into CPT at all because we've got our answer. Okay. Any questions on that one? Okay. Let's do number two. A 7-year-old female presents to the same day surgery unit for a tonsillectomy. During the surgery, the physician notices that the adenoids are very inflamed and they must be taken out as well. The adenoids, although they are not planned for removal, are removed following our tonsillectomy. So what CPT code or codes should we report? So how do we want to do this one? Do we want to go look at the two that have 42825? That sound like a plan? Okay. Go to 42825. So 42825 is a tonsillectomy, primary or secondary, younger than 12. Okay. And then if we actually look directly above that, so we've got our 42820 and 21, right? So 42820 is our tonsillectomy and adenoidectomy. So 42825 is our tonsils only, right? 42820 and 21 are tonsils and adenoids. So do you think we should keep them split up or do you think we should report them together?
Report together.
Yep. So then we need to just find our correct age. So yep, 42820 because they are 7, which is younger than 12. So we're just going to report 42820. So if you don't have it written in your book already, next to the 42820 and 21, write your tonsils and adenoids. Between the 25 and 26, it's tonsils only. Between 30 and 36, those are adenoids only.
Can you say that again? Like what between 42820 and 42821, tonsils and adenoids, and then between 428 and 42825 and 42826, what I put in between those ones?
Tonsils only. And then between the 30 and the 36 are your adenoids only.
Oh yeah, where can I put it? Like on the side, should I maybe like draw a triangle, like and then put adenoid add
Wherever it's going to make sense for you to see it. Just know that your combo is the one at the top, the one in the middle is your tonsils only, and then the bottom 4 are your adenoids only. Tansy, what's your question, hon?
Hi, sorry, I'm just going to make this question quick. My question is, let so I see here there was another option to code them separately. Would we code them separately if the physician did this on a separate day? I'm just
Yes.
wondering when.
Yes.
Okay.
If they were done on the same or on separate days, yes, you would absolutely split them up. But because this is on the same day and during the same session, then they're
Okay.
removing them both. If we were to do them separately, like separate the codes, but do them at the same time, we would get twice our pre-op and twice our post-op fee.
Okay. That
So
makes
that's why we
sense.
want to make sure that we report the one with the combo. Yep.
Okay,
Good
perfect.
question. Yes, very good question. Okay. Any other questions on that one? All right. Number three, so we're looking at ICD-10 and CPT codes. Which ones represent the creation of an opening into the stomach to insert a temporary feeding tube for nutritional support in an adult patient with proximal esophageal carcinoma due to alcohol dependence? And there's a note that a gastric tube was not created. So, me personally, I would look at the F10.20 because that's either going to rule out the two or it's going to confirm the two. So, let's go to F10.20. So, F10.20 is alcohol dependence uncomplicated. So, we've got that here, right? So, we've got our alcohol dependence. So, we know it's got to be either C or D. We're going to rule out A and B. And then we need to look at, is it C15.3 or C15.9 for our cancer?
Tiffany, could we start with the neoplasm table? Would that be quicker? Would you
If
suggest that
if
since they're all
you
different?
are quicker in it, yeah, absolutely.
Okay.
I personally am too, but I know not many people are as quick and confident with the neoplasm table. But yes, if that is easier for you, then 100% you can do that. Me personally, whenever I take exams, I don't go directly to my tabular because I'm so confident with my index because I've been doing it for so long that it's quicker for me to go through the index and find my code versus going straight to the tabular too. Because you'll find, and I think this is the one of the ones. So let's look at the C15.3 versus the C15.9. Yeah, so this one, C15.3 is the upper third of the esophagus. C15.9 is unspecified. So if you're not sure what this proximal area is, then when you go to your table of neoplasms for the esophagus and then you go down to the proximal, then it's going to give you the C15.3. So if you're not 100% confident with your med term, then yes, absolutely your table of neoplasms is going to be faster.
Okay. Thank you.
You're welcome.
Well,
Absolutely.
we already know our answer.
Yep. What's your question, Tansy?
Sorry, I'm trying not to
You're
ask
fine.
too many questions.
No, you're totally fine. That's what we're here for.
But I actually just went straight to the CPT because I have a problem
Yeah.
with taking up too much time on the questions in the exam. Like, I think I average around like 3 minutes, which isn't good. So I'm trying to find shortcuts. Do
Sure.
you recommend, if the CPT, like all the codes are all different, do you recommend doing that? Or do you recommend doing the ICD-10 route for this?
Well, if all of your codes are completely different and you have options to rule out with your ICD-10, I would say go to your ICD-10 because you're going to be able to rule out two quicker than you would rule out two with your CPT, right? Because it could
Okay.
be the fourth one that you look at. So that's going to obviously take all that time to go through all four. But if you do two of them with your ICD-10 and then you still have two options left, then obviously it's going to be easier or it's going to be quicker to go to just two CPTs versus four, if that makes sense.
Okay.
Yeah.
Thank you.
You're welcome. Absolutely. Okay. Any other questions?
I do.
Okay.
Could you do me a favor and go the
Yeah.
route of the neoplasm? Like what would you look up first?
In the table of neoplasms. So
Yeah,
I would go to without I'm opening it up now. I am going to go to the table of neoplasms and then go to esophagus, and then let me tell you where it would be from there. Esophagus. Um, I thought they had proximal in there because they have distal.
Yeah,
Oh, they
they
do.
do.
They do. Yeah. Sorry, my eyes were playing tricks on me. So down to esophagus, and then you would do proximal, and then it would be your malignant primate.
perfect. Thank you.
You're welcome. I don't know if your eyes played tricks like me and you just skipped over that proximal the 3 times that you looked at the list. Okay. Any other questions? All right. So now go to number 4. So what CPT coding is reported when a physician makes 2 separate incisions to perform a laparoscopic appendectomy and a laparoscopic cholecystectomy? So we have 2 that have the exact same CPT codes, right? We just have a different modifier.
Modifier.
Yep. So let's go look at the 45762, just that way we can see which one is which.
Or 47562, you mean?
475, yeah. 47562. So the 47562 is a laparoscopic surgical cholecystectomy. So we know that's our right code. And then the 44970 is our laparoscopy surgical for the appendectomy. Okay. So with that being said, do we need the 51 or the 59?
51. If
Okay.
that's the one that means a separate procedure.
51 is multiple procedures. 59 is your separate and distinct.
Oh, they're both laparoscopic.
Mm-hmm.
Yeah,
So I think they'd be 50.
so okay, sorry. 51 is when we're doing multiple procedures on the same site, right?
Yes, same site, same incision. Yeah. Yep.
Okay.
Same what's the word? Same session, things like that. Yep. And then our 59, this is going to be your key thing because we have 2 separate incisions. So if there are 2 separate incisions, then that makes it a separate and distinct procedure. So it should be a 59. So 51 is if they do it during the same incision. 59 would be if they, in that, like this scenario, they've done 2 separate incisions. Okay. Now, keep in mind that if they are in doing a something on the bowel, okay, and during the same incision, during the same scope, they're going in and they're doing a procedure on the bowel, but they do what's known as an incidental finding and just happen to see that the appendix is inflamed and then make the medical decision to remove that appendix during that procedure. At that point, again, that's going to be what's known as an incidental finding, and it would not be reported at all. Because when you do an appendectomy, it really is just like a 2-minute procedure, right? It probably will take a couple minutes, but it's not going to be like a full blown, like we're going to have to spend 45 minutes doing a procedure. Okay. So if they are in there doing a colon procedure or any other procedure laparoscopically, and then they happen to find that the appendix is inflamed and they determine that it's best to remove it before it ruptures or that it starts to show symptoms, then you would not report it separately. But because here they are doing two separate incisions, so they are intentionally going in and removing the gallbladder and then intentionally removing the appendectomy. They didn't just happen to see that the appendix was inflamed while they were doing the gallbladder. Does that part make sense?
Do you mean you don't report the procedure or you don't
Yes.
report the modifier? Okay.
You would not report the procedure for the appendectomy, period. So again, that's what's known as an incidental finding. So if they were never in there, they would have never known that the appendix was inflamed, right? So it just happened to be a coincidence that they were in there, they saw it, they removed it. Okay, so just keep that in mind.
So there's no code, Tiffany, for that type of incident, I should say.
Not for that type of incident, no. No.
Okay.
No, you would only report whatever the original procedure is that they went in to perform. So if it's a colectomy, if it's a, I'm trying to think of what else they would probably be in there for, and they would find it. Typically when they're doing that, then they are either doing an open procedure, right? And they're doing like an exploratory laparotomy, and then they find something else, and then they also remove the appendix. Or they're going in to do a colon procedure for like a rectal, or not a rectal, but maybe like a colectomy or to resect something or whatever. And then from there, they see it. So they're like, hey, since we're in here, we're going to go ahead and remove it type thing. Yeah. So you would just report the colectomy, the hemicolectomy, whatever it is that you were originally went in to do, and basically just bundle in that appendectomy with the procedure that's being done.
Okay.
Okay.
Yeah. Thank you.
I know that's a little confusing. So just make sure that you remember, and if you don't think you'll remember, put a note in there that incidental appendectomies are not reported separately. Okay. Any other questions? All right. Number 5. Patient presents with a 2-centimeter benign lip lesion. The provider decides to remove the lesion along with a portion of the lip by performing a wedge excision. A single layered suture repair is performed. So what CPT code or codes will we report? So we have 2 options that have the same, right? We have 2 that have 11442. And then we also have 2 that have 405. Actually, we technically have 3 that have 40510. So which one do you guys want to look at first? Do you want to look at the 11 code or the 40 code?
I think the 40 code, because this procedure took out a portion of the lip. So it kind of went beyond the skin.
Okay. Yep. So let's go look at the 40510. So 40510 is an excision of lip, transverse wedge excision with primary closure. So we know 40510 is our code, right? But the main question is, do we report an integumentary for the single layered closure? Do we report that separately, or do we only report the 40510?
Only the. Go ahead.
Sorry. Sorry. No, done.
No, I would have said just alone because it includes the repair.
Yep. Yep. It includes your primary closure. Yep. Perfect.
Okay, Tiffany. So let's say if the closure was not just a single layer, let's say they had to go in more, would we then code like the additional code?
It depends on how they do it. Because if you look down underneath the codes, right? So your 40525, if they're reconstructing it with the local flap, then we would still not report the flap separate, right? Because it's included in the 40525. If they do a reconstruction with a cross lip flap, then it would be 40527. So it depends on the closure.
Okay.
It depends on
Okay.
what type of repair is being done. If it's a layered closure, that's a really good question. Let me see if I can get an answer on that real quick.
Okay, sorry about that.
No, you are totally fine. Let me see if my encoder is going to work. It's been acting funny all day. So I'm not sure if it's going to work, to be totally honest. 40510. Looking. Conditioner. So all of your debridements are included, excisions included. So no, you would not code intermediate or complex repair separately. It's going to be included in. So when they say primary closure, I had to see what their definition of a primary closure is. But their definition of a primary closure is going to basically be that first closure and not any type of reconstructive work. Yeah. So all of your closures, regardless of how many layers of sutures that they place, would be included.
Okay, perfect. That's good to know.
Good question. Yeah, you made me use my brain tonight.
Sorry.
No, you're totally fine. All right. Any other questions on that one? Okay. Number 6, we're looking at CPT and ICD-10 codes for this one for a gastric restriction by placing a gastric band via a laparoscopic surgery for a patient that is diagnosed as morbidly obese, having a BMI of 43, type 2 diabetes, and elevated blood sugar readings daily.
All of them have Z6841.
Okay. Yep. So that one's not really going to matter, right? Because we know it's there. So let's not spend too much time going to look at it. Okay.
Right.
One thing
You
I can
have.
tell. Oh, sorry.
No, you're fine. Go ahead.
One thing I can tell is that I know E10.9 is for type 1, and I know E11, like the 11 codes are for type 2. So
Yep.
I was able to kind of process
Yeah.
of elimination just by that.
Yep, absolutely. If you are at that point where you know E10 is type 1 and E11 is type 2, absolutely you can rule it out that way. Even if you don't, right? Because you have 2 that have the 10 and 2 that have the 11, you can go and rule it out and look it up that way. So correct. So we will eliminate the E10s because we have type 2. Okay. And then E66.01 is in both, right? So let's not spend time looking at that. So we are going to have to look at CPT codes for this one. We have to look at either 43842 or 43770. So let's go take a look at those two and see what the differences are. So 43842 is a gastric restrictive procedure without gastric bypass for morbid obesity, and it's for a vertical banded gastroplasty. Okay. So let's go look at the 43770, which is right next to it. And that is a laparoscopy surgical gastric restrictive procedure, placement of an adjustable gastric restrictive device, such as a gastric band and gastric port components. Okay. So which one do you think on this one? Okay, so I've got a 43770 for the laparoscopic surgical gastric restrictive procedure. Any other? Okay, got another 43770. Anybody think it should be the 43842?
No.
Perfect. Does anybody notice a typo in this multiple choice? Okay, I want everybody to do something real quick. And I keep meaning to change this, and I keep forgetting to do it. I always say during whatever I'm going through, I always say, I need to change this, and I don't. And then I forget until I'm going through it again. Look, everybody go to your alphabetic index for the ICD-10 and go to diabetes. Okay, so this is just a little bit of a heads up. So if we go to diabetes, and then we go to type 2, actually, sorry, not type 2. We're going to go diabetes, and then we're going to go uncontrolled because they tell us specifically that it's uncontrolled, right? And then elevated blood sugar readings are going to be hyperglycemia, right? So that tells us to look at diabetes by type. So it would be our type 2, and then with hyperglycemia. So let's flip the page back. Go to our diabetes, type 2 with our hyperglycemia. What code should our multiple choice have? Instead of E11.9, what code should we use in the real world?
11.65.
65.
Yep. E11.65. Yep. So in the instance that you do use your alphabetic index, okay, and you are looking at diabetes type 2 with your hyperglycemia because they tell us that they have that elevated blood sugar readings, and you see E11.65, but none of your scenarios have E11.65, at that point, choose the one that makes more sense. And we know that we're going to rule out the 10, right? Because again, that's type 1. And then we know that they just have a typo, right? But we're able to find the correct answer based on our CPT, right? But again, it's not one of those things that, and I think I've submitted feedback on this one to AAPC and had them updated, but I just keep forgetting to change my document, and I should. But that's just kind of a heads up that you might have one question that is close, right? But if you don't have one that is exactly what you need, and you have two that are very similar, then go with those. And then, or if you're not comfortable ruling it out that way, then start looking at other ICD-10s to see if you can rule it out, or look at your CPT codes and see. I'm not sure what you're asking about eliminating because it's in the other procedures. So procedures and diagnoses are going to be different. So that's why I'm not following your question.
No, I'm asking, you are saying the C is the answer, so it's a laparoscopy. So do I need to look at in the laparoscopy procedure?
Well, in here it has that it's a laparoscopic surgery. Yeah. And then our CPT code, the 43770, specifically states that it's a laparoscopic procedure.
Thank you.
Yeah, you're welcome. Okay. Any other questions? Okay. Let's do number 7. So a patient is seen in the gastroenterologist clinic for a diagnostic colonoscopy. When performing the service, the physician notes they note suspicious looking polyps and then removes 3 using a smear technique in order to send to pathology for further testing. So we have 2 that have 45378. We have 2 that have 45380, and then we have 2 that have 45385. So which one do you guys want to look at first? We can look at 3 codes and rule out 2 either way.
I think we should do the 4, 5. Yeah, the 4, 5, 3,
Yep.
7, 8. Yeah.
Okay, let's go look at 4, 5, 3, 7, 8. So your 4, 5, 3, 7, 8, that is for a colonoscopy flexible diagnostic, including collection of specimens by brushing or washing when performed. So we did do a diagnostic, right? We started out diagnostically, but then we found polyps and removed them. So should we report the diagnostic in addition to our surgical?
No.
Correct. Anytime you have scopes, whether it be colonoscopies, endoscopies, laparoscopies, anything, arthroscopy, any type of scope, right? If your diagnostic is converted into a procedure, we are going to absorb the diagnostic portion into the surgical procedure. So we should only report the surgical. Okay. That is with any body area, that is with anything like that. Okay. So now we just need to determine, is it 45380 or is it 45385? So what's the difference between 80 and 85?
85 includes the removal.
Okay. Yep. So we're not doing biopsies per se, right? We are removing polyps with your snare technique. Yep. So your snare technique is going to be the 45385, right? Everybody see that? Everybody agree?
Okay, so I learned something new. Okay, so basically if a patient comes in for, like, to be looked in for a diagnostic, and then it turns into a surgery, we only code for the surgery.
Yep. Yep. And that's with any of your scopes. Yep.
Okay. Is this also kind of like a general rule? Like,
Mhm. Yep.
Okay. That's
Yep.
good to know.
Yep. Any scopes, any part of the body, you go in and you look around and you find something wrong and you determine that it's best to do the procedure while you're in, then you would do only the surgical scope, surgical procedure. Yep.
When would you use like the other is the thing listed? I don't sorry. I just
What other thing?
I don't know what to say, to be honest with you. Sorry about that.
No, you're fine. Are you asking when we would code them both?
Yeah, when you would code another thing.
So the only time that you would code both, okay, is if we went in the morning and did a diagnostic, found something wrong, and then we decided to go in and do the surgery later in the afternoon. That's the only time that it would be separate, but it would be a 59 and not a 51.
59 is separate,
Yes.
and 51 is multiple procedures on the same.
During the same session. Correct.
Okay, yeah, I'm just.
I know they're similar, but very different all at the same time.
Okay, Tiffany, sorry, one last question. Well,
No, you're fine.
maybe
You're
not
fine.
the last question. So was I sorry. So was I right for choosing modifier 51 in the sense of thinking that if it didn't switch to surgical, like let's say if it was done in the same session, I guess. Was
Mhm.
I right for choosing that?
No, even if especially if it's done in the same session, you would still only report the surgical. You should
Okay.
not report diagnostic and surgical during the same session of the same procedure.
Okay.
Okay.
And that code's for 1 polyp or 10 polyps, correct? Same
Correct.
code?
Yes, because it says tumor, tumors, polyps, or other lesions. Anytime it has that S in the parentheses, It doesn't matter if you do 1 or you do 50. Obviously, 50 is a little overkill, but it doesn't matter how many you do, you just report a single unit, correct? Okay, any other questions?
Tiffany, just a question.
Yeah.
Then in general, then is the 45378 code only used for diagnostic then primarily?
Yes. Yep, it is only a diagnostic.
Okay.
So it does say it includes the collection of specimens by brushing or washing. So essentially, if they just go in and they rinse it out and it falls off, that's the easiest way to put it, right? That's when it would end up being a diagnostic with a 45378 because they're not truly doing a surgical procedure to remove the polyp.
Okay, gotcha.
Yep.
Okay,
So
thank you.
45378 essentially should only ever be used by itself.
Okay.
Okay. And then also, if you guys notice, underneath 45385, you do have a parenthetical note that says do not report 45385 in conjunction with 45378.
I was just about to say that. You took the
And
words
that's
out of my
underneath
mouth.
all of your surgical procedures underneath that endoscopy or that colonoscopy group. Yep.
Wow,
Yep.
I'm going to
So
highlight that now.
Yeah. All of your do not reports, I always underline those in red. So that way it's just, again, that stop, do not go, make sure you look at me before you try to code something else with it. Yep. Okay. Any other questions? Okay. Number 8, we have a 20-year-old patient presents to the hospital for a sigmoidoscopy due to a history of bloody stools for 3 weeks duration. The patient was prepped and the sigmoid scope was passed without difficulty to about 40 centimeters. The entire mucosal lining was erythematosus. There was no friability of the overlying mucosa and no bleeding noted. No pseudopolyps were found. Biopsies were taken at about 30 centimeters, and these were thought to be representative of the mucosa in general. The scope was retracted and no other abnormalities were seen. So do we want to rule out with, how do we want to do it? You want to do ICD-10? Because we've got 2 and 2. Okay. So let's look at K62.5. So K62.5 is our hemorrhage of the anus and rectum. And then K92.1 is melena. So do we think it's going to be hemorrhage of the rectum and anus, or do we think it's going to be the melena?
I think it's the hemorrhage. Oh, I don't know.
Are they
I don't really know what
saying
melena
there is
means.
hemorrhage? Okay, so you don't know what melena is. Melena is going to be basically blood that is found in the stools.
Okay.
No bleeding,
Oh,
it says.
okay.
No bleeding. So it wouldn't be that one, would it?
Correct. So it would not be the hemorrhage. Yep.
It would either be B or D.
Okay. So yeah, we need K92 point. Yep.
I'm sorry, Tiffany. Since I didn't
No, you're
know
fine.
that word, how would I figure out what that means?
So if you're not 100% confident on it during the exam, go into your alphabetic index and do blood and stool.
Okay.
Yep. So anytime you're not 100% sure and you're not confident in it, go to your alphabetic index. That's why I always tell people you want to make sure that you know how to use your index, because obviously real world, you're going to need to know it. But if you need to go to your index for whatever reason to help rule things out, make sure that you're comfortable enough with it to find it fairly quickly. Or yeah, yeah. Okay, so we've got our K92.1 for the blood in the stools. And then we need to decide, is it the 45331 or the 45305? So 45331 is a sigmoidoscopy flexible with biopsy single or multiple. And then 45305 is a proctosigmoidoscopy with biopsy single or multiple. Okay. Yep, it's going to be your 45331 for the sigmoidoscopy. And they did the biopsies that were taken at about 30 centimeters. Okay. Any other questions on that one? Or any questions on that one? All right. Number 9, a 4-year-old patient who accidentally ingests Valium that is found in his mother's purse is found unconscious and rushed to the ED. The child is treated by the ED physician who inserted a tube orally into the stomach and performed a gastric lavage, removing the stomach contents.
What is Valium?
It is a anxiety medication that is, I
Oh,
think it's considered a controlled substance. I think Valium is a controlled substance.
oh wow, that's a disturbing scenario, I have to admit.
Yeah. You'll see a lot of this in EDs, unfortunately. Okay. So we
ED short for
have,
emergency department.
yep.
Okay, sorry about that.
No, you're fine. So we have 2 that have T42.71, or you have 2 that have R40.20. Which one do you want to go with? I say let's go to the T42s because we know that we're going to have to use a drug code, right? Whereas the R is going to be a sign or symptom. So let's do T42.71. So T42.71 is poisoning by an unspecified anti-epileptic and a sedative hypnotic drug, accidental. Okay. So with your drug codes, I will tell you this. Going straight to your tabular is probably going to cause you more headaches because you're not going to know, is Valium considered an if you're not super familiar with it. Okay. So let's go ahead and look at the table of drugs and chemicals and then find your Valium, and you will find your code much faster that way. So table of drugs and chemicals. Go to Valium, and then which column are we going to go to in the table of drugs and chemicals for this scenario?
Accidental.
Yep. Poisoning accidental. So what's our code for
T42.4x1.
Valium?
T42.4x1A.
Okay. So we only have one with that code, right?
Yep, we know the answer now.
Yep. So we know our answer. Okay. Any questions on that one? So anytime you have poisonings, overdoses, anything like that, instead of going directly to your tabular, because you can see that those code descriptions aren't going to be very specific. They're going to be more chemical names than anything. So go ahead and go straight to your table of drugs and chemicals, find your drug, and then usually you'll be able to rule them out pretty quickly. Okay, any questions on that one? All right, number 10. An 11-year-old patient is seen in the OR for a secondary palatoplasty for complete unilateral cleft palate. Shortly after general anesthesia is administered, the patient begins to seethe, and the surgeon quickly terminates the surgery in order to stabilize the patient. So before we even look at codes, if we have a surgery that was terminated due to the health of the patient, which modifier are we going to use?
53.
Yep. 53 for a discontinued procedure, right? 52 is for reduced. 53 is if they have to do it for the health or well-being of the patient. So without even opening our book, we've already ruled out 2. So both of our codes for ICD-10 are the same, Q35.9 and R56.9. So we know we have to go to the CPT. So let's go to 42215 and 42220. So 42215 is for a palatoplasty for a cleft palate major revision. And then 42220 is for that palatoplasty for cleft palate secondary lengthening procedure. Okay, so everybody agree that it should be the 42220 because it is for that secondary procedure?
I also have a question. The lengthening part, what does that mean? Because lengthening wasn't specified in this scenario.
So for this one, let me see what. Since they're doing it secondary and they're doing it because of the unilateral cleft palate, they're having basically what they're having to do. So they're having to extend that palate over. So that's where your lengthening procedure is going to come into play.
Okay.
Yep, I know. They didn't give you that keyword, but the keyword that they are giving you is the secondary. And so we have to go with the one that has secondary in it versus the major revision, which is going to be that first procedure.
Okay, thank you.
You're welcome. Okay. Any other questions? So we did all 10 questions in 50 minutes. So we did pretty good tonight. Even though you all had some really good questions, we still went through them fairly quickly. So obviously we had a lot of conversation, so we didn't do the 2.4 minutes per question. But that is, essentially we did pretty good with process of elimination outside of all of the questions and things like that. Okay. Any other questions?
I have a
So-
quick question.
Okay.
Yeah.
On the testing,
Mhm.
do you get more points for the cases than, say, the
Nope.
individual questions?
Everything is worth 1 point.
Okay.
It doesn't matter if your case study is a page long or you have one question that is one sentence. They are all worth the same.
Okay. I was
So-
trying to determine if they were.
Yeah. So
worth
what I
more, if
always
you should
tell
do them
people is
first.
keep your cases for the end, right? Because since they're worth the most, or since they're worth the same points, and they're going to take the most time, do the ones that are shorter because you're going to get more points out of all of the others combined, not like individually, but combined, you're going to have more points. So if you have to guess on your case studies, you're only guessing on 10, versus if you do your case studies at the beginning or the middle, and you have 15 to 20 questions that you have to guess on, which one would you rather guess on? 10 or 15 to 20? So do whatever you're going to be able to get done quicker and more confidently while you are not pressed for time, I guess is the best way to put it. And then if you have to guess, it's better to guess on fewer if they're worth the exact same amount of points.
Okay,
So
perfect. Thanks.
for me, like I said, like when I got a 60 on my practice exam 5, I was encouraged. I don't know if that motivated me to study less. I mean, I know 60 is not passing, but it's definitely the best score that I've gotten. It's just like with practice exam 6, I feel like I'm never gonna get it.
Well, I don't know. Honestly, I don't know that if I took practice exam 6, I don't know if the first time I got it, I probably wouldn't do the best on that either. Practice exam 6 is hard. And it's the
Yeah,
hardest
so
of all the practice exams that are out there. So don't let that one be the one that discourages you.
so would you probably say hold off on taking that one for a while?
Yeah. Yeah. I would definitely make sure that you understand everything to be able to do the letters before you get into the numbers.
What do you mean the letters?
The A, B, C, D, E, F.
What do you mean A, B, C, D, E, F? Sorry, I'm just.
Well, there's practice exams A through F, and then there's practice exams 1 through 6.
Well,
A through F are available on the AAPC website, but the ones that are 1 through 6 are only available through AAPC licensed programs.
So just to let you know, the reason, like because my program that I studied for came with a 1-year membership to AAPC and the practice exams, and those were the ones that they had were just for 4, 5, and 6. Those were the ones that they had.
Okay, so yeah, if it's numbers 4, 5, and 6, those are going to be the most difficult.
Okay, yeah. So what would you recommend doing?
I would work on the ones that are either the lower numbers or the ones that have letters, and make sure that you can comprehend the material on those before you get into the ones that are the more difficult with the more advanced topics.
Yeah, like I think it's just like I know I've said this many times. Ever since I got a job as a surgical biller, I don't feel like I want my certification as much, but people are saying, like that's what they do, even if I don't use it.
Well, it's totally up to you. I mean, nobody's going to be able to make that call but you. If you don't want it, don't feel pressured into taking it.
I mean, there's a part of me that then will look back and then like maybe regret. I wish this is when I wish I had a crystal ball, then I could know
I
like,
know.
okay,
Yeah.
well,
I know. It's a hard situation to be in for sure, especially if you love what you're doing in the billing aspect now. It's hard to say, am I going to want to do coding later? Because you never know if, I mean, like you said, you wish you had that crystal ball to be able to say in 5 years, am I still going to be happy doing it, or am I going to wish that I had done it?
like it's just the thing with me is like when coding from scratch, I don't know if it's because I read them quickly, I get stressed out.
Yeah. Yeah. Well, when you're coding from scratch, when you're in the real world, it's going to be different. You're going to have more detail. You're going to have the option to query the provider if you're confused on, different aspects of it or different details. And if you need more information, it's not going to be this is what you're given. Good luck, like regardless of whether there's enough information or not. So in the real world, your coding from scratch is going to be different than what
And
you're
like
seeing on questions.
and also like I mean, what do you think about like what I told you, like my reasons for not studying like for 3 weeks? I mean, the way how I'm kind of trying to study now, but though I get distracted, is rewatching some of the study videos of the ones that I was the weakest in, because I'm usually looking to practice exam 5.
Well, I mean, you've got some pretty legit reasons, to be totally honest. It's one of those things that, unfortunately, when life throws one thing at you, it throws 7 things at you at the same time. So
Like, what do you
it's really just kind of one of those things that, I mean, you have to kind of adapt to the situation and the circumstances.
what are you referring to when you say situation? Because that thing that was a disappointment a few weeks ago, it wasn't grief. It was I'll just say a desire that I really wanted kept getting deferred, and it was really upsetting me.
Sure. I mean, and by situations, I just mean just life in general, whether it be you've had a bad day at work, you've had a bad day personally, you've had a good day and you haven't felt like studying. I'm not going to lie. I've had days where I'm like, you know what? I'm having a great day. I'm not going to sit down and stress myself out to study. And that's totally fine.
Yeah,
Yeah.
I think it's just, I just wish it's just like with practice exams, one, so you would say, where can I find practice exams A, B, and C?
You can get those on either the AAPC website or you can purchase them from Legacy Education.
Okay, AAPC.
Mhm.
Yeah, because you think probably if, I don't know why they just came with 4, 5, and 6.
It just depends on what program you got,
It
to
was
be
that,
totally honest.
well, thank you for your time. So would you probably say that like what would be your advice with regards to like the studying and me not studying for like almost studying that long for 3?
I mean, unfortunately, I'm not going to be able to I can't tell you when to study. I can't tell you you should be doing this instead of this. Everybody's life is completely different. Just do what you can. That's the only thing that you can do.
Well, thank you.
Mhm.
Good night.
Hi, Tiffany. I have a
Hey, Tansy.
question.
Yeah.
My name's Laura. I'm brand new.
Oh, sorry. I thought that was
Um,
Tansy that was talking.
oh, sorry. No, this is me. I hope you can
No,
hear
you're
me.
totally
I have
fine.
my freeze dryer running in the background. But I am starting my course on
Mhm.
November 1st. So I don't have my CPT book yet, but I was
Gotcha.
following along with the ICD-10.
Mhm.
And that was going okay. My question to you is, because I want, I paid attention to everything to learn everything I could.
Yeah.
My question to you is, I follow you on Facebook and on YouTube, everything.
Good.
And I want to know what words should I use, like on YouTube or something, to find the very beginning of like your study group
So there's
or
actually a
anything
full
else.
playlist. So if you go to the Legacy Education um channel, I was trying to think of the
Uh-huh.
word. If you
Yep.
go to the channel,
Yep.
on there should be a tab that instead of it saying videos, it says playlist.
Okay.
And then on there, there's a couple different playlists. Just look for the CPC Study Group 2024 and then scroll
Okay.
all the way down because they should be organized with the newest at the top. If you
Okay.
scroll all the way down, then that's the oldest, or basically it starts at the very, very beginning.
Okay. So when someone, starts their course with their CPT book and their ICD-9, so where do they go from there? So do you have like on your playlist, do they hop onto your playlist then, to help themselves?
Yeah, yeah,
Um,
absolutely.
okay.
So if you're starting, are you doing the AAPC course?
Yes.
Okay, so when you're doing your AAPC course, you don't want to start following along with the study group until you get to at least chapter 3.
Chapter 3?
Chapter 3 and 4 is going to be where you're going to want to start because we didn't do chapters 1 and 2 from a study group standpoint because that's just
Okay.
anatomy and physiology and then kind of like the quote unquote business of medicine.
Okay.
We're only covering the actual like coding concepts
Okay.
that are on the exam. So chapter 3 is where you want to kind of really start to follow it.
Okay. Sounds great. Also,
Okay.
I wanted to let you know, I also went to Michael's and picked up my pens, so I'm all ready to go. So
Yay! Exciting. Did you get the same ones that I have?
I did. I
Good.
did.
I love them. I love them.
Okay.
I don't know why.
They look pretty good.
Because
I'm
I've prepped my
excited.
book for years and years and years. And then one day, yeah, the pens that I had used for the longest time, they were Papermate, and they were the
Uh-huh.
Take Note ones, but they were the dual ended. And I loved them. And then like those pens just disappeared. I had no idea where they went, and it frustrated the bejesus out of me. So I was just sitting here one day and I was struggling with, the pens to use and I was trying different ones and I was like, wait a minute, why don't I just try scrapbook pens? And then it was just, yeah, it was like a
They're
whole
pretty cool.
life changing for me. Yeah.
Yep. I like them. Thanks for the tip. I appreciate it. I hope you have
Yeah.
a great night.
You too. Thank you.
Thank you.
All right, Tansy. Sorry, I was trying to get to you.
Hey, Tiffany. I just had a question. So I'm having a problem with time management, just making sure to get through the scenarios in a timely manner. I know
Mhm.
they give us 2.5 minutes each scenario. I'm really only I feel like I'm getting closer to 3 minutes because I like to reread and make sure everything is correct. And
Mhm.
I notice outside of the testing, uh the tests and the exams, I'm answering every question correct, but then when I get into the exam, it's like, oh, I'm in a rush. I start feeling anxious and I'm like, oh, what do
Just
I
the
do?
pressure of it. Yeah.
Yeah, what do you recommend for that?
Um, Try to get out of your own head. And I know that's so much
Okay.
easier said than done. I really do because I'm the same way. When I'm on my own time and it's not like an official exam, like the pressure is not there, right?
Yeah,
But
exactly.
when you're in the exam, just the pressure and the testing anxiety and the what ifs, and everything's kind of riding on it. Trust me, I get it. That feeling is not easy to dismiss. And that's why I hesitated because I was like, do I say it? Do I not say it?
Yeah.
That's just kind of one of those things that you just have to tell yourself at the end of the day. And trust me, I know it's so much easier what I'm saying than actually like putting it into practice because I'm the worst about it because I do the same thing. But eventually, what I had to realize is, like I said, I have 7 and I'm working on my 8th certification. So I've been through plenty of the
Oh,
exams
wow.
myself, right? But
Mhm.
you just kind of have to tell yourself that this is not a life or death situation, right? I know you've paid money for it. I know that it's a big deal to take the exam, but if you don't, you don't, right? Don't stress yourself out so much that it ends up like hindering your thought process. Okay. And do as much practice as you can prior to so that your confidence outweighs your nervousness. Okay. So, meaning do your book prep, do all of your practice exams, do everything that's going to make you not second guess yourself because that is your worst enemy. Okay. And I know
Yes.
my first couple exams that I took, if I had an hour left, I went back and I changed answers. Don't do that. Your gut is telling you to go with that answer. So go with that answer. Don't even look at it if you have not flagged that question.
Okay. Thank you.
You're welcome.
So I have
I
a
know
question.
it's so much easier said than done, but I promise you'll get there.
I think that's what I needed to hear. Thanks,
Yeah,
Tiffany.
good. You're welcome. Absolutely. Sorry, Sarah. I didn't mean to cut you off.
No, that's fine. On that note, you said when go with your gut, go with it.
Hmm.
I've taken the ABC practice exams,
Hmm.
and at the end of it, I'm like, I feel pretty good.
Yeah.
Yet my score doesn't reflect the same feeling.
Exactly. Yeah, that's me too.
Yeah.
Do you feel like your areas of weakness change every time? Do you
Yes.
feel like they're not consistent? It's not like every time you are constantly low in integumentary and digestive and medicine. You kind of feel like they jump a lot.
Um, yeah, there'll be some that I have lower in a couple of the areas, but
Mhm.
not like on all 3 exams. Is it the
Okay.
same?
So there's not really like a quote unquote consistent low score,
No, it's kind of all of the above.
kind of all over the place. Yeah,
Yeah.
I know. Trust me, that's got to be frustrating because you're like, why was it good on this one? And then it wasn't good on this one. And then, yeah.
Yeah.
What have you done any book prep?
Um, some I've done some highlighting
Mhm.
and circling in the CPT, more in the CPT than anything in the ICD-10.
Yeah. Yeah. Honestly, the only thing I prep in the ICD-10 is just the guidelines. I don't do anything in the actual book itself. I know that there are some people out there that do offer book prep for like the tabular list of ICD-10, but honestly, it's already got everything in there. So why bog it down?
Right.
So no, I completely empathize and support the fact that you prep your CPT more than your ICD-10. So don't feel bad on that. That was gonna usually when that's what and I don't want to push book prep on anybody because I don't want anybody to feel like you have to or you're not gonna pass. But usually book prepping, going through your guidelines and just making sure that those important things stand out, that will help you just overall be a little bit more confident in your answers. And by
Okay.
confident, I mean like you have the right one, not you just feel good about the overall experience, right? So if you have those, and that's what I was saying, if you have those consistent low areas, just focus on prepping those certain sections. But it sounds like maybe just focusing on that book prep, and Carmen can kind of attest to this because we've had a couple conversations, me and her individually, about it during some coaching sessions. If you have days where you feel like if I have to sit down and look at another scenario one more time tonight, my head might explode and I might lose my actual sanity, right?
Mhm.
Book prepping is what I like to call light studying, right? Because you may not realize that you're studying, but if you underline a word, if you write a word, if you highlight a word, your brain's going to subconsciously remember that you've highlighted something. You may not remember exactly what it said, but you might remember, hey, I remember that I wrote something or I underlined something about a guideline that had something to do with, right? And then that's going to kind of trigger your brain to say, okay, I need to go look at that guideline real quick. So even though you feel like you're not really doing a whole lot, you're still studying without realizing that you're studying. Because a lot of people think, oh, well, book prep's just busy work, all of that kind of stuff. And I've heard that comment a lot is, oh, it's just busy work. It just wastes your time. And I'm like, but you're really like, you're remembering it, you're studying it, and you don't realize you're studying it type thing. So
Mhm.
maybe that might help. I don't know if that's kind of kind of the answer that you were looking for. I don't know. I don't really know.
Very
Like,
helpful.
it's such a hard question to answer because everybody's gonna retain the information differently. So that's why, I don't say, oh, well, just go out and listen to YouTube videos or just read your guidelines or, whatever, because there's gonna be some people that they read it and they process it. Me, I would have to read it 8 times for my brain to process it. So I have to, as I'm reading, mentally make those notes. And like, even though I'm not rewriting the whole paragraph, I remember if I highlighted something that said something, or if I underlined it or made it stand out for something, then that's the way that like my brain processes it type thing. So,
Perfect.
okay.
Great suggestions. Thank you.
You're welcome. Absolutely. And then I'm sorry, the person that's user, what was your name? That asked about videos on book prep.
Laura,
Laura.
sorry.
Laura.
Yeah.
For some reason I was gonna say Lindsay, but I was like, no, that's not it. And I
I
didn't
don't
want to
know
like
why I
completely
said
say the
user
wrong thing.
because I did sign in, so I don't know what
No, you're
happened there, but
you're totally fine. So I don't have quote unquote videos on book prep, but I do have book prep documents that are available that you can purchase. And
okay.
it basically walks you through page by page and says, write this here, underline this. This is an important part. Use this to underline to make this stand out type thing. So you can go on to medicalbillco.com/CPC.
Okay.
And on there are like different book prep documents. You can either buy them all at once in a certain package, or if you only want to focus on certain areas at once, then you can do that too.
Okay. All right. Thank you.
Yep.
While I have your attention, I'll ask you another question.
Yeah, of course.
For some reason, I'm intrigued by well, now I'm not even going to remember the name of it. Oh, darn of it. Radiology. What is it? But I don't see a course for it anywhere.
Just for
Um,
radiology specific.
yeah. Yep. It's
Um,
can't remember. It's something radiology.
the interventional radiology.
Yes, interventional radiology. Yes. And for
Girl,
some
you're
reason that
better than
intrigues
mine
me.
because I avoid that like the plague.
Okay.
I do know, let me look. I know that I think there is a certification out there for interventional radiology. So let me look real. I'm pulling up the
It must not be
AAPC
very
site.
popular, or it must not be. I've never seen any
It
jobs
is
for
a
it.
very specialized area that, how do we put it? Cardiology and interventional radiology is like the redheaded stepchild that nobody wants to talk about or acknowledge. So It is, unless you know that you want it or you work in a cardiologist office that does do interventional radiology, most people usually steer clear away from it. But if you
Okay.
are interested in it, there is absolutely a course out there. I just found it. So I'm pulling, or I just found it. So it's the CIRCC.
Oh, that,
And it does
okay.
come with a course. So you can
Okay.
do the course. And the nice thing is if you do these specialized courses, they will typically, uh, so yeah, you get a practice exam, you get 2 attempts for your exam, you get the course, obviously, and then you get a study guide that comes with it. Now, one of
Okay.
the other things is they do tend to run specials on it every now and then. And when they do, they will include what's known as the specialty guide in there with it. And what it is I will show you the specialty guide.
Okay.
It is, it's neurosurgery. Where is it? My brain is skipping right over it tonight. I thought they had an intervention radiology specialty guide.
There it is. To the right. Up, down a little bit.
Nope. Oh,
Right there.
the
Don't go any further. Go up.
cardiology and cardiothoracic.
No. Up a level. To the right.
Up a level.
To the right. Right there.
Okay, but yeah, that's just radiology. So it probably will include the
Oh,
interventional radiology in
okay.
it, but it's gonna include all of your radiology too.
Okay.
But yeah, I mean that's always an option to do for sure. I'll be honest, I have the specialty guide for cardiology because that's the certification I'm studying for. And from a studying for the certification standpoint, it doesn't really add a whole lot of added value, to be totally
Oh,
honest, from the specialty guide. But in the real world, it absolutely will.
okay.
Yeah,
So
so
how
that's just
are
kind of
you
a little
liking
food
the
for thought.
cardiology? Because that was my other thought was cardiology. Um,
Well,
are you liking that? How's that going?
cardiology has always been my weakest topic, to be told, like total transparency, and people that have been on the calls for a while have heard me say it multiple times. Cardiology is kind of like I know enough to muddle my way through it and to be able to explain things, but I would never be able to go work in a cardiologist office because I just struggle with it. And so that was my goal for the year, was to become confident enough in my ability to
Okay.
interpret cardiology charts and
Yeah.
things like that. Um, so I'm getting there. I'll be totally honest. I'm nowhere near there. I have a month and a half until I schedule or until I sit for my exam. So we'll find out. So like whenever I was telling Luke, like I get it. Like there's some days that I just do not have it in me between working 2 jobs and doing coaching and doing all of the things
Yeah.
that I do. It's like some days I just don't have the energy, or I'm having a really good day and I'm not going to sit down and stress myself out.
Yeah.
So, I mean, cardiology is interesting. Don't get me wrong. Like I've always found it interesting, but because it is such a complex system, um, I mean, it's difficult. It's
Okay.
not an easy subject to become a master in for sure. So yes and no. I feel good about it. If
Yeah.
that makes sense.
Yeah. It sure does. I wish I would have found you before I signed up for AACP for my CPC. That's all
Yeah.
I got to say. Because it
Yeah.
was after I signed up and paid everything, and later I found you and I went, oh, great,
I
So,
know. I wish I had, because I hear that so much. And it's like, I wish I had this little magic wand to just say, hey, before you sign up, call me. Like, not
yeah.
because I want to be like the only person that people to go to, but at the same time, like, the AAPC it works great for some people, right? I mean, there are some people that do
Yeah.
it and they do great with it. But then there's some people that need that additional support. And if you are one
Yeah.
of those people that needs that additional support, there's nothing wrong with it. It's just some people, like we've said, some people learn completely different.
Yeah.
And just sitting and
Well,
watching videos is not the way to go if if that's the case.
Right. I saw today on one of the Facebook groups, 3 people in on one post, and I this just astounds me that
Mhm.
3 people said they failed the exam 8 times.
Yeah.
How is that possible? 8
Yeah.
times. Were you not prepared the first time? Apparently not.
It
Right?
depends on the program, because there are some programs that do not offer AAPC material. And the programs, for lack of better words, trying to think of, since this is recorded, I don't want to say my true thoughts, but for lack of better words, like, they don't focus on the important parts. Um, so it is, some courses focus more on billing, and then they do coding.
Yeah.
And whenever somebody goes
Yep.
in to take a coding exam, they're not prepared because they just don't
Yep.
know the ins and outs of the
Yep.
modifiers and the guidelines, and what's truly included and what should be separate and all of that kind of stuff. So that's why I like to make sure that people know that if you're wanting to do your CPC, stay away from programs that promote billing and coding, because they typically
Right.
will only prepare you for a billing certification.
Right. Right.
And there's some people that say, well, I got my CBCS. Unfortunately, that is not a widely recognized certification. That is considered a billing certification and not a coding certification. So a lot of your employers will not recognize that, and they will not even consider that for a coding position. So
Right.
just because it has billing and coding does not mean that it's a coding certification. So yeah, Sarah, so yours was the HEMA. Yeah, it did a good amount of coding. Your HEMAs typically do focus more on coding than billing, because their certifications are around like coding and inpatient coding and all of that. So yeah, absolutely. A HEMA, usually ones that market a HEMA programs are typically the better, of the ones that, for coding certifications for sure.
Yeah, the only thing I didn't like was all of the HEMA focused.
Yeah. The
on it.
different domains. Yeah.
Yeah. And
Yeah.
when
Well,
HEMA
and
stu-
with your HEMA, did you do CCS or CCA?
I could have done a CCA,
Mhm.
but why when I knew I wanted a CPC?
Yeah.
And
Yeah.
DeVry didn't offer a CPC until this year, and I started
Mm.
last year. So
Yeah.
I just
And they
kinda,
wouldn't let you convert the program
well, I didn't find out that they did, like I said,
until
until
after you were done.
well, I had like 2 classes left.
Yeah.
So
Yeah.
there was
Gosh,
like no
that
point.
stinks. Yeah. 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 If you know that you want to do professional side of coding, then absolutely the CPC. If you know you want to do facility coding, then absolutely the CCS. And there's a couple of places out there that will say, oh, if you have both, it increases your chance. And it's like, but not if you know which path you want to go. Yeah. Yeah. But if you don't know, then it is good to have both, because you're like, I'm open to either one. Yeah, absolutely. It'll increase your chances. But if you know you want to go for doctor's offices and professional side of things, then yeah, your CPC is definitely a more marketable option than the CCS.
Yeah, which is what I wanted to do.
Yeah.
When I said I wanted to start, I wanted to
Yeah.
go, physician based, outpatient based.
Mm-hmm. Yeah.
And
Yeah. And there's a lot of people that'll say, oh, if you only have CPC, if you only have a HEMA, or not a HEMA, if you only have AAPC, and I'm like, guys, I've only had AAPC credentials for 17 years, and I feel like I've made a pretty dang good, career for myself. So it's not a matter of CCS is better and you're not a good coder if you don't have your CCS. And that's why in the entry level group right now, there's a lot of conversation about, facilities better, facility pays better, facility this, facility that. And I'm like, but not everybody wants to do facility. So it's a double-edged sword for sure.
guess it depends if you're money motivated or
Yeah,
motivated.
exactly. Yeah. Or if you just, you want to do something because that's what you want to do. Yeah. And I mean, honestly, for where I'm at in my career, I probably make as much as an inpatient coder. So it may take you a little bit longer to get there if you quote unquote only have AAPC credentials. but you'll get there. It's just a matter of the longevity of it, or do you want to make it directly out of the gate? Yeah. All right, guys. I know we're running over, and it's getting late.
One last question.
Yeah,
So
yeah.
are you saying that inpatient coders make more than outpatient?
Well, for one, hang on. Before I answer that question, I'm going to go on a soapbox for a second. So inpatient coders are going to be like your facility coders. You are going to have
Yeah.
outpatient facility coders, but CPC is professional coding. So professional coding can be done inpatient or outpatient. So it's the professional
Oh.
side of services, whereas the inpatient facility is going to be your CCS. Okay. So that's a big
Okay.
kind of misconception that's out there right now is CCS is
Yeah.
inpatient, CPC is outpatient. And it's like,
Outpatient.
it's not. It is professional. Professional can be inpatient or outpatient setting. But that's a whole
Okay.
soapbox I could go on for. So I just wanted to kind of put that out there.
Glad you
But
did.
directly out of the gate, CCS will, and I don't want to say for sure, but it potentially does make a little bit more money directly out of the gate. It all depends on the company that you get into. Your insurance companies, to be totally honest, that's the thought I've always worked on. Well, majority of this worked on. Your insurance companies are going to pay the same rate for an entry level medical coder as a facility CCS coder. So it really just depends on the route that you take from a coding standpoint as far as which one is going to make the most money.
Okay. Thank you.
Yeah, I know that's kind of a loaded answer because there's not really a magic wand of this
No.
one for sure makes more. There's no really guarantee. It's just all going to be a matter of one, it's going to matter of where you live too. Two, it's going to
Exactly. That's
matter
what I was
if you're
gonna
a
say.
remote job where they're located. Because like my company is headquartered in Kentucky. We don't really get locality pay. So people that live in California, we don't really have a whole lot of California employees because they don't really give a locality raise type thing. Some companies will, some companies won't. So it really just depends on the company and all of that.
I
Makes
have,
sense to me. Yep.
and also if you like PCS. I
Yes,
don't like PCS.
I don't either. I tried to learn it. My brain did not want to absorb it. It shut down.
Mhm.
I thought I had a hard time with cardiology, and PCS like immediately made me realize I wanted nothing to do with facility coding. I swear
Yep.
they make up their own like words and their own
Words.
rules, and it's a mess.
Yep. One more quick question. Sorry, you said I've always worked in the insurance side of
Mhm.
things. Do they normally post jobs on the normal job posting sites? Because I've never seen one for an insurance based.
Some of them will. The best way to find them is to go directly on their websites.
Okay. Thank you.
Yeah, absolutely. Yeah, some of them will. I know that like Aetna, I know that Cigna, and I know that what's the other really big one? Blue Cross Blue Shield. I'm not sure where they typically post their stuff, to be totally honest. Honestly, I don't know that I've seen a lot of jobs out there for Blue Cross Blue Shield, but that doesn't mean that there's
They
not. I've
are
just never come across them.
they are per state. Every state has Blue Cross and Blue Shield. Right.
Yeah.
So
Yeah.
I would imagine it's Blue Cross Blue Shield. I'm Michigan. So Blue Cross Blue Shield in Michigan. So Blue Cross Blue Shield in Kentucky, whatever.
Right. Right. Yeah. It's just a matter of I don't know what job site they actually list on. So I don't know if it's on the Anthem site like themselves or if they have additional sites for each state. I don't know how it works from an Anthem standpoint, to be totally honest. So yeah, I don't know. I'll have to look into that and maybe I can give some insight into that next week.
Thanks so much, Tiffany. I really enjoyed tonight. I appreciate
Yeah,
it.
absolutely. Of course. If I'm here if you guys need anything, but if not, I will talk to you all next week.
Thank you. Good night.
Thanks. Have a great
Thanks. You too.
week. Thank you. Bye-bye.
Bye-bye.